Welcome to today's UCLAMDChat webinar. My name is Dr. Justine Lee. I am a craniofacial and pediatric plastic surgeon and the Bernard G. Sarnett Endowed Chair in Craniofacial Biology at the UCLA Division of Plastic and Reconstructive Surgery. And today our topic is craniosynostosis, treatment options and developmental outcomes. Feel free to ask questions on Twitter or Facebook using hashtag UCLAMDChat. So the goals of today's talk is to talk about what is craniosynostosis. That's a common question that I hear from parents, and also to distinguish craniosynostosis with positional plagiocephaly or deformational plagiocephaly. And also to talk about what does it mean for your child if she or he has craniosynostosis, discuss the types of craniosynostosis and the treatment for the different craniosynostoses, and also a short segment on microcephaly and craniosynostosis in children with microcephaly. So usually my parents will come to me and ask me, my newborn has a funny looking head and what should I do? So the first step is the first step for all medical diagnoses is figure out what the diagnosis is. See your pediatrician, see what she or he thinks, and usually they'll be able to give you some kind of idea and some kind of opinion on whether or not it's a surgical problem or a non-surgical problem. If your pediatrician is still unclear, ask for a referral to an American Board of Plastic Surgery certified pediatric plastic and craniofacial surgeon. And you can find out who is board certified by checking the American Society of Plastic Surgeons website. After you get a diagnosis, then you can start to think about treatment options. And these are broadly categorized into surgical and non-surgical. So let's start with the major differences in diagnoses. So craniosynostosis versus positional plagiocephaly. So craniosynostosis is an actual fusion of bones of the skull, resulting in an inability for the skull to expand as the brain grows. So you can imagine as the baby's brain grows, you'll often feel that area that's soft. So that's actually a gap between the bones, and this expands. So the cranial skull, the skull itself, or as we call it sometimes a cranial vault, expands as the brain expands. Versus positional plagiocephaly, now this is a flattening of the skull or some sort of deformation of the skull due to positioning the baby, very commonly seen due to the Back to Sleep campaign, and also sometimes when there's some muscle tightness. So that's called torticollis. Sometimes the baby tends to favor one side or another, and that results in a little bit of flatness of the head wherever the baby tends to favor. So unlike positional plagiocephaly, craniosynostosis is a surgical problem and requires operative correction, whereas positional plagiocephaly is never a surgical problem, and this is usually corrected with some non-operative types of treatment, with the exception of when there's really tight muscles in the neck that's causing the plagiocephaly. So to give you an idea what this looks like, take a look at these two babies. So one has a head shape that looks like this. So this is kind of like what we call like a parallelogram. So it's almost like a little rectangle sort of. And this is more like a trapezoid. All right, so these are the two different head shapes. Now one of them is positional plagiocephaly, and the other one is craniosynostosis. Now take a look at the ears. So this is how the ears are positioned. In this kind of parallelogram shape head, this ear is kind of positioned more anteriorly, closer to the front of the head. This is positioned slightly posteriorly. Now this, on the other hand, is positioned more posteriorly towards the back of the head, and this side is positioned about normal to anteriorly. So the one on your right here, or on my right here, is unicoronal craniosynostosis. So this is a surgical problem. This one is positional plagiocephaly, which is a non-surgical problem. And another way to kind of know is that positional plagiocephaly usually makes sense. So if the back of the head here is flat, the brain gets pushed this way, and so you sort of see a little protrusion on the front of the head here. And also, the brain gets also pushed this way, you see a little protrusion here, and that sort of makes sense. Whereas on this side, it doesn't quite make sense. You would think that there's some flatness here. Well, you would think that the brain would then get pushed this way, but actually no, it's flattened on this side. So that doesn't quite make sense, and when it doesn't make sense, then generally it's time to see a surgeon. Okay. Now, what do you do about the non-surgical problems? So when you have positional plagiocephaly or deformational plagiocephaly, it's sometimes called the baby flathead syndrome. And because it's caused by positioning, you solve it with positioning too. So you start with things like supervised tummy time, or when the baby's sleeping. I had to do this with my niece. We put rice bags on either side of her head, and that prevents the baby from sleeping flat on her head. And of course, sometimes when it's a favoring problem where the baby tends to favor the right side, sometimes what you would need to do is turn the baby the other way around so that they start looking towards their left. Babies always try to look at their parents, so if you move them around, you can kind of actually encourage them to look the other way, even if they have tight muscles in their neck. And this usually resolves as babies start to move around on his or her own as they roll around and all that. And so it tends to resolve itself. In very severe cases, sometimes helmet therapy is recommended if positioning exercises really aren't making any headway. And this is started pretty early, just a few months of life. Now, craniosynostosis now, or surgical problem, what is it? It's the premature ossification of cranial sutures. So this is what a typical skull looks like with craniosynostosis. Even to the naked eye, you can see it looks a little bit elongated. And why? It's because this suture here, which is an opening between two cranial bones, is actually fused. Now, the incidence is about 1 in 2,500 live births, and it sometimes can result in elevated intracranial pressure, and it has been associated with decreased developmental outcomes, and the only solution is surgery. So a little bit about what the skull looks like normally. So you have a couple of bones that are of interest here. So this is your frontal bone. This is the front of the face is over here, or the front of the head is over here. So this encompasses your forehead as well as part of your scalp that's underneath the hair-bearing area. Here are the parietal bones on either side of the head, and the occipital bone, which is in the back of the head. Now the cranial sutures here, this is what's called your sagittal suture, straight down the middle of the head. And then this is called the coronal suture that goes across the head. This is called the metopic suture that goes right down the forehead. And then this back here is called the lambdoid suture, so that goes in the back. So these sutures, these names will actually come into play as we start to talk about the different types of craniosynostosis. So the normal closure of cranial sutures, for the metopic suture, which again is the one straight down the forehead, that's the only one that really closes during infancy. So about a year of age or less, the metopic suture will normally close. Everything else doesn't close until you're 20, 30, 40, and then in some instances it never fully closes. There's always still a little gap there. So you can imagine any baby with closure of any of these three sutures is definitely abnormal. And any baby that has earlier closure of the metopic suture, it will become evident either as a ridge down the forehead or an actual abnormal head shape. So what are the functional risks of having craniosynostosis? The major risk is that the baby may develop in a way that is decreased in terms of the cognitive abilities or developmental abilities. And this is typically thought to be related to an increase in pressure. Like I said before, the brain, as it grows, needs room to grow. So when your skull or your cranial vault is not growing with the brain, then you would imagine that there's some pressure on the brain. And so the way we diagnose elevated intracranial pressure is we tend to refer babies to pediatric ophthalmology, and what your ophthalmologist can do is look in the eye and see if there's sort of pressure around the optic nerve. This is called papilledema. And as the eyes are a window into the brain, that's kind of an indication indirectly of increased pressure in the brain. Changes in behavior and headaches can sometimes be seen, and of course some imaging is always helpful. So if we see some imaging and we actually see some impressions of the brain into the bone, then you can imagine that there's a little bit extra pressure on the cranial vault from the brain's growth. Long-term neuropsychological disturbances have been reported, and that's probably the major reason to do this surgery. And in addition to that, facial asymmetries can occur, especially when it affects just one suture towards the front of the skull. The risks of operating on babies with craniosynostosis are pretty straightforward. The first risk is blood loss, the second risk is blood loss, and the third risk is still blood loss. And then beyond that, there's sort of the standard risks of surgery like anesthesia and infection, which are pretty rare. Infections are pretty rare in these babies. Down the line, continued head shape abnormalities, and the potential for reoperation in children who don't completely heal their cranial defects. Every once in a while, a kid will come back maybe like 6, 7, 8 years down the road, and there's still going to be like a small little soft spot, and sometimes we may need to operate on these children if they don't heal. Before your child's surgery, because blood loss is such the most important thing to discuss, I always recommend a really long discussion and really consider some things to do. And I'll talk about what I usually recommend for parents. I usually tell parents to really consider directed blood donation. This basically means that you would then donate blood specifically for your child, and then the blood bank would then check it to make sure that it's compatible with your child, and this can be done about 10 days or so before surgery. Not usually much sooner than that, mainly because the blood doesn't last permanently, so you don't want to do it right away after diagnosis, but do it closer to the time of surgery. Blood transfusions. Just because you have directed blood donation and transfusion potentially from you to your child, it doesn't necessarily mean that your child won't need somebody else's blood also. And every surgery differs on how much blood the child loses, and so it's always possible. Now, we have operated on patients who have religious objections to blood transfusion, and that is also possible, but all the risks need to be very thoroughly discussed, and all options need to be thoroughly discussed before proceeding forward, but that can happen too. And lastly, as an adjunct, erythropoietin, sometimes known as EPO, sometimes known as Procrit. Now, this is a factor that actually helps your baby produce more red blood cells prior to surgery. And the way we usually give it is starting 3 weeks before surgery. It'll be an injection every week until surgery. And then, of course, this is a team effort here. We don't do these surgeries without our pediatric neurosurgical colleagues, so it's always advisable for you to meet the pediatric neurosurgeon who will be working with us on the surgery prior to going forward with the surgery. This is usually done around 6 months of age, but slightly less than 6 months of age. And I'll come back to this in a minute on timing, because we have some good evidence from about 2 years ago on what's optimal timing for children. So let's talk about the most common form of craniosynostosis. It's sagittal synostosis. So remember, the sagittal suture goes straight down the head, and it's characterized by a boat-shaped head. It's called scaphocephaly, and it's more common in boys than in girls. And this is what it looks like. So here's a photo of a baby with scaphocephaly. Here's the front of the head. Here's the back of the head. This is a CT scan that you would typically see that goes with it. There's a three-dimensional reconstruction of it. Here is your abnormal suture. So see how there's it's not completely open here. There are areas that are already fused. And so because it's fused, the baby has no ability to grow this way, right? The baby only has ability to grow this way, so towards the front or towards the back. And hence, the skull becomes more and more elongated as time goes on. Now, from a side view, same thing, towards the back or towards the front, more and more elongated. Now, the way we correct this is through an open cranial vault technique. So there are some nuances and differences in technique from surgeon to surgeon and center to center, but they're general concepts that remain constant. So I'll just show you what we typically do, and I'll also discuss the differences in technique in a minute too. So here's the skull again. Here are the open sutures that you see. Here is the abnormal suture outlined in red. So what we typically do is our neurosurgical colleagues will come in and take out this abnormal suture for us. Okay, so now you see a skull, the suture is now out, And then what we do is we make cuts in the parietal bones. So these are the parietal bones again. So we make cuts that look like this, and a little square cut there, a little square cut here. And the reason for these cuts are basically to remodel the entire cranial vault. And then there's some other cuts that it's very difficult for me to show here, but they're called barrel stave cuts on the sides of the head, and that really opens things up on the sides of the head. So after we're done making those cuts, we then actually shave off a good portion of the ends, the most anterior portion of the bone. So this is about like a centimeter and a half. And usually at this point, the skull actually starts to kind of bounce back into a more rounded shape. And to help that out, we put these wires here that actually help pull the parts of the skull together, rounding out the skull, and also because we have these cuts on the side, this also expands the skull from the sides too. And this is called a reverse pie technique, sometimes the other way around, meaning that some people do it differently, and it's called the pie technique. But basically, this is like the symbol pi, okay? And this is what we typically see before and after. So this is a baby before. You can see some narrowing from side to side, and this then becomes widened after surgery. And from a side view, you see a really elongated head shape, and this is much more rounded now. And I typically like to use this lazy S incision here. It hides really well in the hair. And after the hair grows out, maybe about a year or so out, you really don't see much. Some people do the incision that goes all the way across the head. That's fine too. It's just not as easily hidden. So now let's talk about differences in surgical techniques. So there are basically two categories of surgical correction for sagittal synostosis that you can do. One is our open technique, which is what I showed you. There's also one called the endoscopic suturectomy with helmet therapy. Basically what that means is you take out the suture and then you mold the head with a helmet afterwards. Now there are pros and cons to both of them. The major pro for the open cranial vault remodeling technique is long-term neuropsychological outcomes. And I'll talk about that in a second. But the con is that, of course, we have this long discussion about blood transfusions, which are frequently necessary. Not always, but frequently. Usually an ICU stay to monitor the baby, a drain. So those are kind of the cons of the open technique. Now the pros of the endoscopic technique is that, not a whole lot of blood loss, perhaps shorter hospital stay. The major con is the long-term neuropsychological outcomes has been recently shown to be inferior to the open technique. And so in 2014, a really great group of surgeons at Yale did a study at multiple centers and showed that the type of surgery and timing matters for correction of sagittal craniosynostosis. This is really huge in our field, mainly because it's really the only study that has really looked at this very carefully, prospectively, multiple centers, and also with multiple tests. And the bottom line conclusions that they came up with is that the open cranial vault remodeling resulted in a higher IQ in children in comparison to those who underwent endoscopic strip craniectomy. And this is not evaluated in babies, but in children as they got quite a bit older. And the timing of surgery before 6 months is also extremely important for the best intellectual outcomes. So with this in mind, the conclusions that we have from these two really excellent studies is that the open technique is superior to the endoscopic technique in terms of long-term neuropsychological outcomes, and it should be done at about 6 months or less. And I'm leaving this, I put up the references here for parents out there who want to actually look it up themselves and see kind of the technical language of what was actually seen. Okay, so moving on forward. Now we don't have such great data for neuropsychological outcomes for any other synostoses. So that is all we have in terms of craniosynostosis. Moving on to the next most common craniosynostosis, that's unicoronal craniosynostosis. And the characteristics are there's flattening of the forehead on the abnormal side, bulging of the forehead on the normal side. The ear is positioned posteriorly. Remember, it looks like a trapezoid. And also, it's more common in females than in males. And this is called anterior plagiocephaly, which is different from the positional or deformational plagiocephaly. And this is what a typical kid will look like. The nose always points towards the abnormal suture. This is what the CT scan looks like. Here's an open suture. Here's the abnormal closed suture. And from the top down, trapezoidal shape here, and here's your closed suture again. Here's a front of the head. So there's the nose and the face that you see there on that CT scan. So what we typically do for this type of craniosynostosis is something called a frontal orbital advancement. Again, it's an open technique. So let me show you. This is the outline of the skull with all the open sutures. Here's your abnormal suture. And again, with our pediatric neurosurgical colleagues, what we'll do is we'll take out the suture. They'll do a craniotomy for us, which is essentially taking a piece of bone from the frontal area off in order for us to reshape the forehead. In addition to that, we'll do a frontal bandeau here. That includes a little bit of the frontal bone, but also the orbits, because you see the orbits are also abnormal in this type of craniosynostosis. So after this is then taken out and the craniotomy is also taken out, this frontal bandeau is then shifted, so it's rotated to the normal side to give room for the brain on this side to grow and also to remodel the orbit on this side. Okay, and this is what a baby looks like before and after frontal orbital advancement. And this is about a year and a half or two later, you wouldn't even know that she had surgery. Bicoronal craniosynostosis. So beyond unicoronal synostosis, it's possible for the fusion to affect actually both sides of the coronal suture. Remember, that goes across the top of the head. So the characteristics of this type of head shape is that it's wide and it's sometimes tall. So the wide head shape is called brachycephaly. The tall head shape is called turicephaly or turibrachycephaly. The eyebrows seem like it's unsupported by a brow bone. It seems like, usually you'd see a nice little protrusion where the brows are, and you don't really see that. From the top, the head shape is flattened from front to back, so it's almost like the exact opposite of scaphocephaly or the sagittal craniosynostosis. And this is what a typical kid looks like. See how the eyebrows look almost unsupported here. Here are the few sutures here. The head shape is a little bit tall and also wide. And this is from the side. Again, eyebrows not really supported, pretty flattened from the front to the back, and it's also pretty tall. And here's your abnormal suture that is fused. And the surgical correction is pretty much the same as unicoronal synostosis. We do a frontal orbital advancement to reshape the forehead, open up the sutures, and also reshape the orbits, the top of the orbits. And this is what the kid looks like afterwards. So now you see better support of the eyebrows. And from the side, most importantly, you see that this is a lot more rounded. The forehead looks remodeled. It's not as high as it used to be. And this, incidentally, is what the incision on the skin looks like a few months after surgery. He's still growing in his hair, so you kind of see a little bit more obviously. But the hair does cover it, not as does cover it. It's not as nice as, say, like the lazy S incision for the sagittal craniosynostosis, but it's usually quite acceptable. Okay, metopic craniosynostosis, the third most common form of craniosynostoses. The characteristics of this type of craniosynostosis is that the eyes appear pretty close together. It's a triangular shaped head and is called trigonocephaly. Now remember, this suture does close, so it's a matter of when does it close. It closes in infancy, but if it closes by the time the baby's born, that's a bit too early. It should close maybe a few months down the line. And this is what it looks like on CT scan. You see a very defined ridge here. It's a better view from the side. You can kind of see how this ridge here is kind of protruding. And when you look at a photo of a baby, you can kind of see that ridge pretty visible there. And then from the vertex view, from the top down, that's probably the most obvious view. It's a triangular shaped head or trigonocephaly, and this is what the baby's head looks like. And after frontal orbital advancement, you see a nice rounded shape of the head, and you can kind of see actually where that incision was still, but this baby grew in some nice hair to cover it up. Okay, The very last craniosynostosis to talk about is lambdoid craniosynostosis. It's the least common form of non-syndromic craniosynostoses. Non-syndromic meaning, none of these are really affiliated with syndromes that I talked about. There are some that are affiliated with syndromes that unfortunately we don't have the time to talk about today. So the characteristics of this type of craniosynostosis, again, the head is kind of trapezoidal from a top view. The ear is positioned posteriorly. It's sometimes called posterior plagiocephaly. And this is what it looks like. Here's your positional plagiocephaly again, looks like a parallelogram, and this looks like a trapezoid. And this is non-surgical, and this is surgical. And the surgeries are kind of similar to a frontal orbital advancement. It basically open up the suture in the back and allow the brain to grow in the back. Okay, a hot topic recently is microcephaly, and maybe some of you out there are wondering, what do we do about craniosynostosis and microcephaly, because all children with microcephaly have craniosynostosis. Well, microcephaly is a different entity because it occurs actually when the brain doesn't develop normally. So it's not that the brain is under pressure from the craniosynostosis, but the other way around. The brain isn't putting any pressure on the skull, on the cranial vault, and therefore the cranial vault is not growing. So in these cases, multiple cranial sutures can fuse. Basically, all of them will fuse. And this can be due to things like, in the news, Zika. It can also be due to things like holoprosencephaly, which is where the brain grows in a way that it's not actually, it doesn't have two lobes, doesn't have a right and left cerebral hemisphere, but actually just one lobe. And in these cases, it is unfortunately non-operative, and these children do have some developmental deficits that may not be completely apparent as babies, but become more apparent as the children grow. And I mentioned briefly that we can't talk about some rare syndromes, but I thought I would show you a few photos. So craniosynostosis is frequently non-syndromic. That is the most common type that you'll run into. But every once in a while, we do have some rare syndromes. Now, this is a craniosynostosis syndrome called Antley-Bixler, and what it has, what this baby has is both coronal synostosis as well as a few other types of craniosynostosis. In addition to that, she has what is called maxillary hypoplasia, which is the face is a bit retruded. And this is kind of a completely different topic, as it is a lifelong type of treatment that may require quite a few more surgeries than the standard non-syndromic craniosynostosis. So in summary, for craniosynostosis, it's important to distinguish it between deformational head shapes, which are treated non-surgically. Treatment of craniosynostosis is surgical, and there's important considerations to discuss and really think about in terms of blood loss prior to surgery. Surgery before 6 months of age and the open technique has been reported to result in improved long-term neuropsychological developmental outcomes. And microcephaly also results in craniosynostosis, but this is usually due to the abnormal growth of the brain. So thank you so much for your attention today, and I'll take your questions. Okay, so a few questions coming from Twitter and Facebook. The first question is, when do cranial sutures fuse? Cranial sutures, the metopic suture that goes straight down the forehead fuses at about a few months of age. So everyone's a little bit different. It could be, as early as 3, 4, 5 months of age. It could be as late as 9, 10, 11, 12 months of age. But during the first year or so of life, it will normally fuse. So a normally fused metopic suture, I should say a fused metopic suture at the age of 2 is very, very normal. Okay. Now, all the other sutures, the coronal suture, the sagittal suture, the lambdoid suture, now that's a different story. They don't fuse until adulthood. So any baby with the fusion of the coronal, sagittal, or lambdoid suture, by definition, has craniosynostosis. Next question is, is it ever too late to operate on craniosynostosis? This is a very controversial question. I've had definite children who have come in who are, say, maybe close to about a year old or so. And we definitely would go ahead and recommend surgery. It's when you get to the ages of, say, 6, 7, 8, 9, 10, and sometimes adults who are never diagnosed with craniosynostosis, what's the best thing to do? And it's pretty controversial, not sure. What we typically do is go ahead and offer both, and then the parents can decide or the patient can decide depending on their age. But at that point, the brain growth is pretty much up to nearly adult size, and the pressure on the brain may not actually matter so much anymore. But generally, if a patient is diagnosed with craniosynostosis, we generally offer surgery. What are the warning signs that intracranial pressures are elevated? So if you're, well, the first thing to do is actually see somebody. So if your ophthalmologist says that you have pressure or your child has pressure, and he or she will call it papilledema, then you know you have an elevation in intracranial pressures. Sometimes it's obvious in behavioral changes or headaches, but that's a little bit less common, especially in babies. It's very difficult to know what babies are feeling. And also, the last thing is on imaging, sometimes we can actually see areas of the skull where the brain has actually did something that we call thumbprinting. Essentially, the brain is pushing into the bone, and the bone actually is molded into the shape of the brain where it's being pushed. Okay, what are the warning signs? Okay, we did that already. Are there extra charges for directed blood donation? No, not that I know of. Not at UCLA. I'm not sure what other institutions do, but we don't have it. Okay, and I think those are all the questions. So thank you again for joining us for another episode of UCLAMDChat. Again, my name is Dr. Justine Lee, and feel free to ask me any questions either now or later on Twitter, Facebook, or just directly emailing us. Hope to see you soon again.